So when I'm talking about the general principles in antimicrobials, basically I'll be covering some part of the history, some very important terms, just like just now I said about minimum inhibitory concentration. But what is important from examination point of view is the classification of antimicrobials. Please star mark there. Classification of antimicrobials. And then sometimes you are also asked on the common problems that is encountered, like toxicity of some important antimicrobials, some hypersensitivity reactions which you will be coming across. Then in the viva you'll be asked, oh, drug resistance. Sometimes theory also drug resistance come. Then I have seen some question papers from some other institutes also where there is a question on combination of antimicrobials. Combination, okay? Then there was a question which came some time ago on prophylactic use of antimicrobials as well as failure of antimicrobial therapy. Okay, now I may finish this class only till drug resistance. So combination of antimicrobials, prophylactic use of antimicrobials, failure and all this, yeah, you please read on your own. They are all theoretical things. You can just combine your understanding of this so the history is like this. Before, somewhere around in the 16th century, in the 17th century, this Chawal Mugra was applied. If there is any injury, if there is any wound, then Chawal Mugra. And then some go to the extremes of, applying mercury. Then, somewhere in the 17th century, if you look at the old movies, you'll find that cinchona bark, the cinchona bark, which we now know and, it has been manufactured, a compound known as quinine. But at that time, the cinchona bark was boiled, okay, the bark was boiled, the bark of the tree was boiled, and it was given to anyone who was having fever with some sort of suspected infection. Now, Paul Ehrlich is a very good person. What he did was, he experimented with the use of methylene blue and trypan red. And then later on, he was the first person who developed arsenical toxel or this arphenamine, okay, for syphilis. Then only penicillin came. And he was the first person, somewhere in 1900s, okay, he said, let me coin a term known as chemotherapy, okay, chemotherapy, where you will treat infections. So Paul Ehrlich is famous, he is known for this. Chemotherapy came from his. Whereas the modern chemotherapy was brought in by Domac. Okay, please remember this particular word, prontosil. So many sulfonamides are being brought out nowadays. So many sulfonamides. When you want to treat some infection or the other, you'll say sulfonamide, sulfonamide. Okay, it was brought out from this particular demonstrating effect of prontosil. Okay, then antibiosis was demonstrated before Paul Ehrlich came into the picture by Alexander Fleming. Okay, then penicillium, you already know that by mistake he kept a bread on his plate, on his table, and then suddenly he saw that there was development of a mole. And that particular mole, when he took out in a petri dish with full of infection, he saw that this particular mole could inhibit the infection around could show a zone of inhibition in the petri dish, and that's why he named this particular mold as penicillium. Okay, whereas the main use of penicillin from penicillium from this mold was brought out by Chain and Florey. Okay. Then this particular person brought out streptomycin. Oh, so important, this drug. There is no treatment of tuberculosis if you cannot bring out streptomycin. Okay, so streptomycin is important. So you have Waxman who brought out streptomycin. Okay. Then afterwards, from 1944, 40, 50 onwards, we get semi-synthetic derivatives. So many drugs are coming out nowadays. Okay. Now, there are some important characteristics of antibiotics you have to understand. If you give a particular antimicrobial agent, it should reach the body part where the infection is occurring. So, if you give a particular tablet or a capsule which you say is an antimicrobial agent, if it doesn't reach the source of the site of infection, then it is not considered an antibiotic or an antimicrobial. Okay. It should not cause the development of resistance. We are seeing nowadays left and right, even with coronavirus, so many patients are coming out with resistant to antiviral drugs, resistant to bronchodilators. It's very sad. Okay. So when an antimicrobial agent is developed, it is being developed, that resistance will not take place. It should not produce undesirable side effects. Look, this is a hypersensitivity type 4 reaction. You should not do this. It should not, when you're giving by injection, it should not cause nerve damage. And it should not irritate the kidney, meaning it should not be nephrotoxic. So when a patient is taking an antimicrobial agent, should not develop constipation, should not develop diarrhea or nausea and vomiting. So characteristically, we say a good antimicrobial agent should reach the site of infection, okay, should reach the site of infection, should be able to produce an action at that particular site of infection. It should not cause any adverse tract reaction which is harmful to the kidney, harmful to the gastrointestinal tract. And if you're giving parenterally or orally, it should not be destroyed by stomach acid. It should not be binded to highly plasma protein bound, because it needs to attain a concentration in the blood to produce its action. When you're saying I'm giving an antimicrobial agent, it's a combination between a drug and it has to produce some effects. Where is that effect? It should be able to work against infectious pathogens. And this infectious pathogens is where is present in the host, who is the patient. So this particular triad, okay, antimicrobial effects should, the goal is to produce an antimicrobial effect against infectious pathogens. And before that, the drug has to enter the host and then has to, overcome the host defenses, kill the infection. And when the drug is entering inside the host also, there are so many pharmacokinetic interactions which are taking place. It may lead to toxicity, or it may be highly protein bound, or the minute it's given orally, it's destroyed by gastric acid, and it may not attain a concentration where it will cause, it will break down the host defense and then kill the infectious pathogen. So this particular triad is important. Just remember this. So these important terms we have to remember. When you say antibacterial agent, it is a substance which is produced from microorganism, be it a bacteria or a fungi like a mold, penicillin, or it is a synthesized substance that produces bacteriostatic or bactericidal effect. Please remember this. It is a broad term when you say antibacterial. Okay, it could be a natural source, natural meaning it is brought out from microorganism, or it is synthesized from microorganism, be it a bacteria, be it a fungi. And it is at the same time, an antibacterial agent can be synthesized chemically. But then the main goal of an antibacterial agent is to produce a bacteriostatic or a bactericidal. Now we'll come to these two terms also. Whereas if you look at an antibiotic, when you say antibiotic, that's where you and me will be confused all the time. Antibiotics can be defined as substances produced only from microorganism, be it a bacteria or a fungi. So the source of an antibiotic has to be natural. Natural means from a bacteria or a fungi. It is not synthesized. If it is synthesized, then we broadly describe it as an antibacterial agent. But the goal is the same. The goal means it has to produce bacteriostatic or bactericidal effect, even at very low concentration. I hope you got this. For example, if I say penicillin, benzyl penicillin. Benzyl penicillin is the main antibiotic which is brought out from a very good source, a fungi, that is that mole, that penicillium mole, Penicillium notatum. So I can safely say that penicillin is an antibiotic. Whereas in that same group of penicillin group of drugs, we have synthetic chemical substances which are also produced, like ampicillin, like amoxicillin. So can I say that amoxicillin is an antibiotic? No. Amoxicillin is an antibacterial. But I can safely say that penicillin is an antibiotic because it has been synthesized, or it has been brought out not synthetically but from a fungi known as Penicillium notatum. When I say antimicrobial spectrum, it means a spectrum of a drug to kill a microorganism or to inhibit the growth of the microorganism. That is a spectrum. It can be narrow spectrum, meaning if I give one antitubercular drug known as isoniazid, see this isoniazid here? If I give isoniazid, it is active only against mycobacteria. Okay, so if you give isoniazid against staph, it will not work. Isoniazid against strep, it will not work. Isoniazid if you give against a virus, it will not work because it has got a narrow spectrum, a narrow activity, specific only for mycobacteria. This is the classic example of a narrow spectrum antibiotic. If I say broad, so nice the word broad, because it can inhibit, it can kill a variety of microbials. Okay, for example, we have two broad spectrum antibiotic, and this is asked all the time. Name two broad spectrum antimicrobials, then you will say tetracyclines and chloramphenicol. Or name two broad spectrum antibiotics, then you have to say tetracyclines and chloramphenicol. Okay, so separate classes will be taken on tetracyclines, separate classes will be taken on chloramphenicol. Now, using a broad spectrum, by being broad, it's so good. It can kill all sorts of microbials, okay? But it also interferes with the normal bacterial flora, especially in the gastrointestinal tract, in the large intestine. It destroys the normal bacterial flora there. Therefore, it can cause a term called superinfection. And because of this superinfection, when you're using a broad spectrum like tetracycline and chloramphenicol, patients will come to you with a number of adverse drug reactions like diarrhea, like candidiasis, because normal bacterial flora has also been inhibited or killed in the process of its antimicrobial action. Now, these two terms are also very important. Bacteriostatic. When I say static, it means stop. Stop means I will just stop you from going anywhere, but I will not kill you. That is called bacteriostatic. Whereas if I say bactericidal, then dangerous, because I will definitely kill. Okay, so bacteriostatic means to stop the growth or the spread. But bactericidal means definitely the microorganisms will be killed. Okay, now these two terms, okay, one drug may be bacteriostatic for staph, but it is bactericidal for mycobacteria. Okay, so it can do two actions. It can be bacteriostatic, it can be bactericidal. Now, chemotherapeutic index is same like your therapeutic index. It is denoted by lethal dose 50 divided by effective dose 50. That means 50 to 50. Okay, and the overall, the chemotherapeutic index is always 1. Minimum inhibitory concentration, that's what I was asking you. Has it been done? You said yes, so I'll just repeat very fast. It prevents visible growth in 18 to 24 hours of incubation. If you look at this, minimum bactericidal concentration is important. Minimum inhibitory prevents the growth, but bactericidal means kill. How much it will kill? It should kill more than 90% of the microbes. Then only you say this is a bactericidal drug. Okay, and then if you want to know resistance to a particular antimicrobial agent, then this is the formula. When the minimum bactericidal concentration is more than 32 into MIC, okay, it indicates that the microorganism has resistance to the drug. For example, look at this. Susceptible organism, and then you find that there is a inhibition here. This is the minimum inhibitory concentration. Here, and here. 4, 8, 16. Okay. Same, this is a test tube where you have already done in microbiology. And this diffusion, you will see the zone of inhibition here. Whereas if you look at the minimum bactericidal concentration and the minimum inhibitory concentration, see, nothing is here. Here, something you can inhibit, minimum bactericidal. And then here you see, 99% of the organisms has been killed. But look here, meaning that your MBC is more than 32 into the minimum inhibitory concentration. And if such a concentration comes, then if you look at the disc in the Petri dish, you will find that there is no zone of inhibition. That's why in such types of concentration between minimum bactericidal concentration and a minimum inhibitory concentration, you say that the resistant organism to that particular antimicrobial agent. Okay, this is the same Kirby-Bauer procedure where you see, the zone of inhibition nicely here. Here there is a little bit zone. Here no. These are all resistant. Okay. Post-antibiotic effect. All the time we come across this. You take an antibiotic or you take an antimicrobial agent for 5 days and then you get all right. Why? Because there is a term known as post-antibiotic effect where the antimicrobial effect stays on in the body even after the concentration decreased below the minimum inhibitory concentration, meaning it's a very effective antibactericidal drug because long after the minimum inhibitory concentration is lost, it's not there in the body, still you have the antibiotic effect. That's why we don't say take antimicrobial for 1 month. No, it is because of the post-antibiotic effect. We know that if you are taking azithromycin for 3 days to 5 days, then you have a post-antibiotic effect. And definitely because of this post-antibiotic effect, you will find that all the organisms in the body are being destroyed or are being killed. You don't have to continue for 10 days or 15 days unless the infection is very severe or the infection is or the microorganism is resistant to that particular antimicrobial. So even if you give for 17, 50, I'm coming to important topics now. Remember this. Classification of antimicrobial drugs. We have many ways to classify them. I'm mixing all, okay? I'm mixing between a chemical, I'm mixing between a source, I'm making against its mechanism of action. So you see here how it happens. When I say classification of antimicrobial agents, I talk about the first thing, a chemical structure, because nowadays we don't get pure antibacterial agents or antivirals or antimicrobials. We get a combination of a chemical synthetic source. So the first drug here you would like to remember is the sulfonamide. Okay, it contains a sulfone ring. And the related drugs are like sulfadiazine, dapsone, or para-aminosalicylic acid. It is impossible for you to remember all this. But from a chemical structure like sulfonamide, please remember this important drug known as dapsone. Or the diaminopyridines, you please remember this drug, trimethoprim, or an antimalarial drug known as pyrimethamine. Quinolones, it's a must. You have to remember quinolones. You have to remember norfloxacin. Beta-lactams, please remember penicillin and cephalosporins. Again, you will ask me, why chemical? Chemical because the beta-lactam rings has got a particular ring where it has got a very good antibacterial activity because of that particular ring. When we do beta-lactams, then you'll understand why I've kept in the chemical structure penicillin and cephalosporins. Tetracyclines, you have because they have 4 rings. Tetra means 4 rings. Okay, so doxycycline. Then a very important nitrobenzene compound. Okay, it has got a nitro group which releases free radicals, that is chloramphenicol. Then the aminoglycosides, because they have got sugar molecule. The macrolides have got sugar molecules. So you have streptomycin, erythromycin, so on and so forth. Then a group of lincosamides are there, like the lincomycin and the clindamycin. I know it's tough to remember. It's very, very tough to remember this. For me, it's simple because I have read this again and again and again. Okay, but try to remember at least one drug, some chemical out of 9 or so many 18 are there. Okay, at least remember 5 chemical structure classification of antimicrobial agents, like nitroimidazoles, meaning they have an imidazoline compound. Okay, it's a very nice hexagonal structure, nitroimidazoline compound, and you have a very good drug, metronidazole. Then somebody contains some vitamins, nicotinic acid, okay, like isoniazid, very important drug. Then you have azoles, okay, some very good antifungal drugs like miconazole, clotrimazole. Everybody is struggling to get azole types of drugs nowadays because of the black fungus, that mucormycosis, and everyone is struggling whether it would be azoles will be effective or polyenes will be effective, or maybe we may have to go to some other compounds where this fungus can be treated. Okay, so scrambling to get antimicrobials, and everybody goes back to the chemical structure of between mucormycosis and the antifungal drugs. It's so interesting. Okay, so try to remember classification of antimicrobials according to chemical. Then you have another classification where the mechanism of action is important. Some drugs, they inhibit the cell wall. Some drugs, they cause leakage from the cell membrane. That means they form pores, they form holes, or they form tunnels in the cell wall, and then it causes leakage. Some may go right into the protein synthesis. Okay, then they inhibit protein synthesis. Some may affect permeability by misreading of the messenger RNA right directly into the genes. Some may just go to ribosomes, some go directly to the genes. Some again will go to the genes, DNA gyrase, DNA function, DNA synthesis, or they inhibit with the metabolism or the of the particular microorganisms. Okay, or if you look at this particular chart, those drugs which will inhibit cell wall synthesis, so many drugs are there. At least remember penicillin. See this penicillin here? At least remember cephalosporins. Those which will inhibit, go inside the nucleus and inhibit DNA gyrase. They've come from the cell wall, go inside the nucleus, inhibit DNA gyrase, quinolones, ciprofloxacin. Those which will directly go to RNA polymerase, you have rifampicin. Okay. Then those which will go to ribosomal enzymes, like they will inhibit 50S protein synthesis, 30S protein synthesis, you have erythromycin, you have tetracyclines. Then, those which will inhibit the metabolism, one way or the other, they inhibit metabolism through dry hydrofolate, this reductase enzyme. Then you have polymyxins, you have trimethoprim, you have sulfonamides, you even have dapsone there. Okay, those which will inhibit both 50 and 30S, you have the broad spectrum antibiotics here, chloramphenicol and the tetracyclines. Please use this particular chart. Please use this particular chart because classification of antimicrobial agents according to mechanism of action may come. Okay, if it comes as a long question, then you've had it. Okay. Now, you can also classify antimicrobial agents. I know it's becoming a little bit tougher and tougher, but please remember, you can directly go against organisms like antibacterials, antifungals, antivirals, antiprotozoals, antihelminthics. Okay, so antibacterials, you have ampicillin, penicillin, erythromycin, streptomycin. Then you have antifungals, ketoconazole, then amphotericin B, crucifilvin. Then you have antivirals. Then all these, so many drugs are there. Okay, antiprotozoals, chloroquine, then antihelminths like mebendazole, parental, niclosamide. So many drugs are there. Okay, you have acyclovir, you have azithromycin. Okay, then these drugs will go against organism. This is much simple to remember, much more simple to remember. Then you have narrow spectrum, penicillin is, then you have the broad spectrum, chloramphenicol and tetracycline. Then those drugs which are purely static, inhibit only the growth, okay, like sulfonamides, erythromycin. Then purely bactericidal, definitely they will kill the microorganism. We have very good drugs like penicillin, aminoglycosides, rifampicin, isoniazid. I'm not asking you to remember each and everything, but today this is the homework for you. Classification of antimicrobial agents against, you take chemical structure, you take mechanism of action, you take spectrum, you take organism. Okay, please try to remember some. This is most important again, how you are bringing out antimicrobials. If you talk about a fungi, that means antibiotic, fungi, or a bacteria, or an actinomyces. Okay, from the soil, actinomyces. All these drugs will come. Fungi, you have penicillin, bacteria, you have polymyxin, actinomyces, you have aminoglycosides, macrolides. So important how you will classify antimicrobials from their source of origin, from where you have got penicillin, from where you have got polymyxin B. The common problems when you are giving antimicrobials. We can manufacture antimicrobial agents and then they should reach site of action. They should not produce toxicity. When you are giving parenterally, they should not cause any pain. But then you will come across antimicrobials with various forms of problems. It may cause toxicity when you are giving orally, it may cause gastric irritation. If you are giving intramuscularly, it may cause pain and abscess. If you are giving IV, it may cause thrombophlebitis, injury, to the intimas and cause thrombophlebitis. And then, if you give systemic, okay, low therapeutic index, that means only for some organisms they will work, like aminoglycosides, tetracyclines and chloramphenicol. Or very low therapeutic index like polymyxin B, vancomycin and amphotericin B, they may not reach. Okay? Or they may cause hypersensitivity reaction ranging from rashes to anaphylactic reaction. And we have done in the practical, especially about the anaphylactic reaction of penicillin. That's why we say, before you give parenteral administration of antimicrobials, you always have to do what? A skin testing. Otherwise, it may range, hypersensitivity may come in the form of rash, or it may go to anaphylactic reaction, which is so dangerous. That's why we say, when you are doing a skin sensitivity testing, you have to get ready with one drug. What was that drug? What drug is that?
Adrenaline.
Adrenaline. Very good. Very good. Thank you. Now I come to another important general consideration of antimicrobial, that is resistance. We talk about resistance to antimicrobial, resistance to antimicrobials. Let's have a look how it takes place. It can be intrinsic. That means the organism itself is producing some form of resistance, like a gram-negative bacteria, bacilla, which is already, it's not working against penicillin. Even at the time when the drug is being brought out during development process, penicillin cannot inhibit gram-negative. So when we talk about gram-negative and you give penicillin, then you are doing injustice to the patient, because from before, penicillin cannot have any antibacterial effect against gram-negative. Rather, if you look at the classification of antimicrobial agents, you would find that for gram-negative, the best will be your aminoglycosides. If you look at the classification which I showed you just now. Okay? Now, acquired resistance. Intrinsic means the drug itself is not having any effect. Acquired means during the course of giving the drug, the antimicrobial agent, you know, these microbes, they are so cunning, they are so clever, they produce resistance. That is called acquired. That is called acquired. Okay, that means penicillin, inherently, from the beginning, it doesn't work against gram-negative. But penicillin may become resistant to some gram-positive bacilli. Why? Because the microbes themselves, they will make the penicillin resistant. We'll come to that now very nicely. Sometimes there is enzymic inactivation. Okay? For example, that's why I was telling you, the microbes, you know, they are so clever, so cunning. They produce this particular enzyme known as beta-lactamase. And this beta-lactamase will cause an acquired resistance. It will cause an acquired resistance. How? Because they will destroy the penicillin. Penicillin works so nicely against strep. It works so nicely against staph. But in the course of its administration, the microbes will produce beta-lactamase to destroy penicillin and cephalosporins. That is called an enzymic inactivation. Again, I'm repeating. Penicillin is very good against gram-positive bacilli or coccis. Okay? But then the coccis and the bacilli, where penicillin should be able to cause antibactericidal action, these microbes will produce beta-lactamase. And this beta-lactamase enzyme, what does it do? It inhibits the action of penicillin. That means it does something to the chemical structure of penicillin or cephalosporins, where they will cause enzymic inactivation. We'll come to that now. Look, this beta-lactamase, what does it do? This is a penicillin structure. Okay, it has got a beta-lactam ring here, very nice, and a thiazolidine ring here. Okay, you change any of these structure, they'll become long-acting. You can make them, from being not possible to inhibit gram-negative, they can also inhibit gram. If you change the structure here, we are not concerned with this. We are concerned with this beta-lactamase, which is being produced by microbes. What it will do, it will attack this particular beta-lactam ring. If it attacks here, say with cephalosporins, if the beta-lactamase attacks in the beta-lactam ring, because cephalosporins also has got same structure like beta-lactams. Okay, this is the beta-lactam ring. If this beta-lactamase goes here or goes here, what does it will do? It will open this. This is the chain. Nice tight chain. If it opens this, the antibacterial activity of penicillin or cephalosporin is lost. That means if it splits the beta-lactam ring, if it opens this chain here, there will be no effect of penicillin, there will be no effect of that. Understood? You know, Alexander Fleming, when he brought out this particular penicillin from that mold, Penicillium notatum, he said, the microbes are educated to resist penicillin. You know, they have a meeting, all the microorganisms, they have a meeting and they say, let's cause resistance to penicillin. and a host of penicillin fast organism is bred out, which can be passed to other individuals and from them to others until they reach someone who gets a pneumonia or septicemia, which penicillin cannot save. See, Alexander Fleming has already given this warning long time ago. That's why we are saying, don't give penicillin without a prescription. So today, all of us, when we talk about antimicrobials, we always remember these particular words of Alexander Fleming. Sometimes, instead of beta-lactamase, these microbes, they will modify the target sites. Instead of going to the beta-lactam, they will, the penicillin binding protein, which is present there in the microbes, that will be modified so that the penicillin cannot go and bind there. Sometimes in other cases like the dihydrofolate reductase, where this particular drug trimethoprim should go and bind in this particular enzyme. But then the dihydrofolate reductase, this particular enzyme, mutates. The structure mutates. So this trimethoprim cannot go and bind there. If you look at drug antagonism, general pharmacology, if you change the binding site, then competitive antagonism, non-competitive antagonism will not take place. The same thing, if you mutate, if you change the enzyme, then this drug cannot go and bind there. If you change the penicillin binding site, inside the organism, okay, then this drug cannot go and bind there. Okay, these beta-lactams, penicillin or cephalosporins cannot go and bind there. If they don't bind, if drug cannot go and bind, okay, then it cannot produce any. Sometimes what they do, these microbes, they are, again I'm saying like Alexander Fleming, they are so clever, they'll develop ways and means to cause resistance. They cause an efflux system, they bring out pumps. They say, okay, when the drug enters inside, I'll throw it out. When the drug enters inside, I'll throw it out. Okay? Another situation is that gram-negative bacteria show a special membrane known as the liposaccharides and then decrease penetrability. These are the efflux transporter. Again, this one we have done, the GP glycoproteins we have done in general pharmacology, where the efflux transporters will not allow the drug to enter inside. They throw them out. They don't throw them out from here, they'll throw them out from here. Okay? Sometimes they make this periplasm or the cytoplasmic membrane so thick and so impermeable that the drug cannot enter inside. Okay, in such cases, if the drug cannot enter inside or it's being thrown away from the surface, then it cannot cause any antibiotic effect leading to resistance. Most important thing is this, genetic alterations. This is what Alexander Fleming is saying. If you mutate, if there is genetic alteration in the genes, like the DNA gyrase gene mutation, definitely quinolones like ciprofloxacin or rifampicin, very good antitubercular drug, will not be able to work. Okay? It could be a single step mutation, it could be a multi-step mutation, anything can happen, like in the form like E. coli resistance or staph resistance, especially Staph aureus. Okay? Genetic alteration can also happen by transduction, like a bacteriophage, bacteria infected with a virus, bacteriophage. Okay? So the protein coat gets infected and the bacteria becomes resistant to a particular antimicrobial, like Staphylococcus aureus. Okay, they develop resistance to penicillin. Like I told you, penicillin is very good against gram-positive, but suddenly because of transduction, where the virus invades the bacteria and causes a mutation, like Staphylococcus aureus, then it causes penicillin resistance. Sometimes bacteriophage carry plasmids that code for penicillinase, okay, or beta-lactamase. Okay, it may not happen only to penicillin. It may happen to tetracycline. It may happen to erythromycin. It may even happen to chloramphenicol. Sometimes by sex linkage, conjugation, the genetic material transfer requires two elements, that is an R-determined plasmid and a resistant transfer factor. Okay, they carry the genes, and then they cause resistance of gram-negative bacilli, which is directly by conjugation. That is a sex linkage. That is a bridge. So it can happen by a simple resistance, a genetic, mutation of the genes, or it can happen by transduction, that is bacteriophage, or it can happen by conjugation through a sex linkage or by way of a bridge. So three genetic mutations can happen, genetic alterations can happen that can cause resistance. Please remember this. One is genetic mutation of the enzyme itself, or transduction or conjugation. This is important for you to remember. Look at this. Don't forget to take a handful of complementary antibiotics on your way out. When penicillin was first brought out into the market, it's being flaunted by the pharmaceutical reps. And they say, take a handful, and that led to resistance. Look at this. Hey kid, wanna be a superbug? Stamp this into your genome. Even penicillin won't be able to harm you. So that's what, when you go through the back door, because this person went through the hospital kitchens, I mean through the back door, then definitely you'll get a handful of antibiotics or antimicrobial agents which will cause resistance. So too much of advertisement against a particular, like we saw recently, everybody went to scramble to get one particular antiviral agent, and it's creating a havoc. Why such advertisements is being brought out? Should not be there, because it can lead to resistance. If it doesn't lead to resistance, it will lead to toxicity one way or the other. It's harmful. Important methods to improve antimicrobial use. Important methods to improve antimicrobial use. Okay? Use combination antimicrobials for prolonged therapy. We will be doing anti-tubercular drugs. We will also be doing anti-malarial drugs. Okay, where you have the artemisinin combined therapy, and then you have also the anti-tubercular combined therapy. Because these particular antimicrobials, when they are working against mycobacterium, or when we working against plasmodium, they have to be taken for a long time. So one particular antimicrobial will not work. So you use a combination if you are to use for a long time. Formulary restrictions. Sometimes you want to combine so many drugs together where one may be bactericidal, one may be bacteriostatic, one may be synergistic, additive, so many of these things. So there must be a formulary. Pharmacy substitution or switch, this is also not good. Now, when we want to start antimicrobial, that's why on Monday there will be a class on antimicrobial stewardship, where it is a multidisciplinary approach when you want to start an antimicrobial. Then interactive prescriber education. You cannot just say, take this antimicrobial agent, do whatever you want. It has to be taken for a specific time with a specific dose. Okay, that's why there is dose optimization. Undue prolonged use, indiscriminate. For viral, don't give antibacterial. That's what we always say. We always give rapid acting narrow spectrum first before we take a broad spectrum. That's why tetracyclines and chloramphenicol are never used just like that. If there is an infection, treat the infection very, very fast. Don't leave it, I'll treat it after some days. No, because there may be genetic alterations, there may be enzymatic alterations, which we have to think nicely, or binding alterations. So if it is a notorious organism, treat it, kill it as fast as possible. Superinfection we have already done. Superinfection like broad spectrum antibiotics, because if you give a broad spectrum, it interferes the normal intestinal flora, it may lead to superinfection. So you're giving a new infection from a previously old infection. And the predisposing factors are always when a patient is already on corticosteroid therapy, or the patient is immunocompromised, like they are already on anti-cancer, or AIDS patient, or diabetics, or intravascular coagulation disorders, or agranulocytosis. So in such instances, to minimize superinfection, you give specific antimicrobials for these infections. Okay, so for small infections, don't give antimicrobials, and then don't give long antimicrobial therapy for a situation which is not needed. Okay, so these are the methods. Like I said, super infection, the first one could be diarrhea. It could be Candida albicans, which you see those white patches, thrush in the mouth, or vulvovaginitis. Sometimes you may get enteritis or Clostridium difficile, or patient may go into UTI or enteritis, which is very dangerous. Very notorious, very sad if a patient comes with Pseudomonas superinfection. Okay, and usually your drugs, you have to give these treatments. I will not go into. There is a failure sometimes. Okay, failure, if there is renal failure, if there is liver failure, this is what we have already done in the practicals also, how you have to do the Gerhardt Plodred's, this one, the table you have to remember all the time. Okay, in renal failure. Same thing in liver diseases, some important drugs which you cannot give, or you have to reduce the dose. Okay, then when you want to combine use of antimicrobials, like I said in tuberculosis, but here this is to achieve synergism. You will give amoxicillin and clavulanic acid. This is already done from general pharmacology. Or when you want to increase the synergism, supra-additive, then you give sulfamethoxazole and trimethoprim, or penicillin and gentamicin in subacute bacterial endocarditis. Or when you want to treat Pseudomonas, you combine cephalosporins like ceftazidime and cefepime. You want to reduce ADRs, adverse drug reactions, best is streptomycin and penicillin. The basis for giving this one here is like this. Streptomycin works against gram-negative, penicillin works against gram-positive. Combined together, they will not allow subacute bacterial endocarditis to happen. Same thing nowadays, there is a rush for cryptococcal meningitis, for your black fungus. You will combine an antifungal amphotericin B and another antifungal fluocytosine. Okay, so amphotericin B, fluocytosine. When you don't want resistance to happen, like in tuberculosis, leprosy, or your H. pylori, remember, or HIV, which we'll be doing. All these drugs, all these systems will be doing. When you want to broaden the spectrum, that means gram-negative, gram-positive, again there will be some Enterobacteriaceae. So for such mixed infection like UTI or brain abscess or some gynecological or surgical infections, then you combine the use of prophylactic use of antimicrobials. This comes as a long question again. Prevent setting of an infection or suppressing an infection before it manifests clinically. Okay, like in rheumatic fever, in tuberculosis, or Mycobacterium avium complex, or HIV, or meningococcal infection, then you have to give prophylaxis. That means even before the development of symptoms, you're already giving drugs. Prophylaxis. Okay? Or prevention of infection in high-risk individuals. Suppose a patient has acute bacterial endocarditis and they want to go a dental extraction, or they have to undergo catheterization or instrumentation, or immunocompromised patient receiving corticosteroids. Then you want to prevent infection in such patients, then you have to give prophylactic use of antimicrobials. Disadvantages are so many. You may, increase the incidence of ADRs, like they may go to the kidney, okay? Increase chances of superinfection, emergence of resistance, and then you increase the cost of therapy. Then, diagnosis becomes very casual and it is usually not rational. So these are the few disadvantages. Prophylactic use in surgery, this is important. Clean, contaminated, and dirty. These are the categories which you'll come across again and again in surgery posting. Okay, so what prophylactic use? And one particular, research is going on now in NIGRIMS regarding clean, contaminated, and dirty surgeries. So again, you give clean what you have to give, clean, contaminated what you have to give, contaminate what you have to give, and dirty. These are all the things. Please have a look from the slides. Failure of antimicrobial, because you don't select properly. Gram-negative, you're giving penicillin, that is wrong. Route or duration, sometimes drugs which are destroyed by gastric HCl, you're giving orally, then that is also wrong. Late treatment initiation, especially in tuberculosis, leprosy, HIV, if you give late treatment initiation, there may be failure. Failure to take necessary adjuvant measures. This is very important. If there is an abscess, you continue giving a local application without drainage of the abscess or empyema, it doesn't work. Poor host defense, again I'm repeating, in immunocompromised patients. Okay. Then if there is a vegetation on the heart parts or in the eyeball, on the blood-brain barrier, very difficult to treat because you cannot expect that the drug will go and reach all these barriers. Okay. Pyrexia of unknown origin, if you treat judiciously by giving antimicrobial therapy, there may be failure because you're not finding out what is the cause of the fever. Sometimes dormant or altered organism, sometimes especially tuberculosis, and then also nowadays HIV and also leprosy. There may be altered organism which later give to rise to relapse. Then in that case also there will be failure of antimicrobial therapy. Any questions? Am I still in tune with everybody? Classify antimicrobials, again I'm saying, from source, chemical structures, spectrum of activity and mechanism of action. Drug resistance, very important, from enzymatic inactivation to binding sites to genetic alterations, which are 3 types, from genetic mutations of the enzymes, or from transduction, bacteriophage, or from conjugation through a bridge, okay, or a sex linkage. Then how will you combine antimicrobials? What are the advantages and the disadvantages? What exactly is antimicrobial therapy prophylaxis? That also you have to know, which are the conditions. And what I did not mention here is surgical antimicrobial prophylaxis.